Welcome for the second whiteboard on valvular heart disease. My name is David Messika-Zaytoun. I'm a cardiologist at the University of Ottawa Heart Institute and chairman of the Canadian Cardiovascular Society Working Group on Valvular Heart Disease. Today, we will discuss streamlining heart valve disease and building effective healthcare pathways. As discussed in the first video, the optimal care pathway for a patient with valvular heart disease involves several key steps as illustrated in the figure. First, diagnosis should be suspected based on symptoms. Critically, the symptoms are non-specific, and that's why it's always important to have in mind valvular heart disease in case of shortness of breath, chest pain, or palpitation. In the absence of symptoms, a valvular heart disease could be suspected by physical examination and auscultation. The diagnosis should be confirmed by echocardiography, which will also provide an assessment of valvular heart disease severity, etiology, mechanism, and consequences. The patient should be then referred to a cardiologist, ideally with expertise in valvular heart disease, who will assess the patient, follow him, and timely refer for an intervention when needed. The referring hospital should have the capability to perform state-of-the-art intervention in a timely manner. Unfortunately, all the steps are flawed. We have a difficult access to family physician, auscultation is not often performed, access to echo is challenging, as access to specialists, we have an insufficient hospital capacity, and long wait time. Timely treatment relies on adequacy between supply and demand. The limited access to treatment, as shown in this figure, is far from anecdotal and leads to an excess rate of death and mortality. This has been clearly shown for AS, aortic stenosis, but it's also true for all valvular heart disease. In addition, access and wait time are not uniform, with marked inequity based on location and socioeconomic status, with longer wait time in rural areas and in patients at low socioeconomic status. But the situation can be improved. We definitively need to increase capacity and allocate more resources to center. But we can also better use the current funding and improve efficiency of the system by better identification and triaging of the patient who needs an intervention urgently, thus reducing admission, and also improving bed occupancy by early discharge. Is, however, supposed to shift some of the resources from inpatient to the outpatient setting. The full healthcare pathway of patients with valvular heart disease should be refined according to the SPOC, hub, and node model of care, where SPOC is the first-line healthcare professional, usually the family physician, in charge of the detection and screening, and of ordering a transthoracic to achieve the diagnosis of valvular heart disease and refer the patient to the hub. The hub is a cardiologist with expertise in valvular heart disease and with access to high-quality echocardiography. It will follow the patient, and once an intervention is indicated, the hub will refer the patient to the node. The node is a valvular heart disease center capable of performing both surgical and transcatheter intervention and of achieving excellent outcomes. A node could also be a hub. Critically, the flow should be bidirectional, and streamline communication between the different providers, ideally using the same EMR, should be promoted. This is important before intervention, but also for the follow-up after the intervention to diagnose early any valve complication and degeneration. When the patient is considered for an intervention, the heart team is key to define the right treatment for the right patient, which is aligned with the patient's goal of care and preferences. The heart team is composed at the very least of one interventional cardiologist, one surgeon, and one interventional echocardiographer, supported by a nurse coordinator. In conclusion, patient with valvular heart disease journey is currently unsatisfactory with multiple bottlenecks. Access and wait time are responsible of an increased rate of death and complication. These issues are not affecting Canadians equally. We need to improve access, wait time, equity through increased capacity, efficiency, and streamlining healthcare pathways with implementation of the SPOC hub node model. Heart team is a key element to define the right treatment to the right patient aligned with his preferences.